Nigeria is among the 30 high TB burden countries due to limited access to TB screening and testing services. But with support from USAID, the National TB Programme, the Stop TB Partnership and aligned stakeholders, Bashir Ahmad, a local radiographer, is able to set up and run systematic rapid screenings in Nigeria's most remote areas. He is on the front line, saving lives, cycling to hard-to-reach communities using the ultra-portable digital X-ray system and computer-aided detection, or AI software.
It's my responsibility to take the examination in terms of position the patient, then we'll collect his samples. CAT for TB is really helping because actually it can detect TB at early stage. That's the first one. And secondly, the heat map can show you the patches around the chest. If there is any patches, you'll see it with your eyes. It's my town, my community, my people. So it's a dream. So I want to give back to them by helping them or by doing this work. It's my passion. I want to follow my passion.
Welcome everyone to the first Delft webinar of 2025. My name is Katyayini and I'll be your host for today's session. Today's topic is navigating AI beyond TB, benefits and opportunities. Next slide, please. We are all currently witnessing how AI-driven chest X-ray screening is expanding beyond TB, with an increasing potential that is being realized for detecting occupational lung diseases, silicosis, and a broad range of respiratory conditions. But how realistic are these expectations, and what more can we expect when it comes to AI in diagnostic imaging? Today, we'll be joined by experts from around the world who will discuss the role of AI in medical imaging, the capabilities, limitations, and challenges. Today, our panelists include Professor Dr. Bram van Ginneken from Radboud University Medical Center, Professor Rodney Ehrlich, Senior Research Scholar from the Division of Occupational Medicine, University of Cape Town, South Africa, Professor Helen Ayles, who's the Professor of Infectious Disease and International Health at the London School of Hygiene and Tropical Medicine, in addition to being a director of Zambart. And last but not the least, we are joined by Edwin Klinkenberg, my colleague, who's going to be talking about establishing trust in emerging AI technologies. Next slide, please. Before we start today's webinar, a couple of things that I want to go through first. This webinar is being simultaneously interpreted in French, Spanish, Russian, and Arabic. So to listen, just click on the interpretation button and select the language of your choice. Additionally, I'm assuming we'll all have questions for all the sessions that we'll be going through today. If you have any questions, please click the question button and answer and put in your question. We'll have a Q&A session in the end, and all your questions will be picked up. In case we have too many and we miss your question, please don't worry. We'll be sending a Q&A answer sheet after this webinar ends. Next slide, please. Without much further ado, I'd like to invite our CEO, Guido Geerts, to discuss the major milestones and the impact our solutions have made last year. Guido, the floor is yours.
Yes, thank you very much. I think we maybe immediately go to the next slide. Yes, indeed. First, I would like to thank you all for taking the time to be at our webinar in this period of some instability and unrest in the world, and especially the people who are quite affected by the USAID cuts and all the other cuts that the governments are doing at the moment. So when I was preparing this presentation, it felt almost old-fashioned to talk about equitable and sustainable healthcare solutions. But I think, especially in these times, it's important to stick to your values. So that's what we're going to discuss today. Maybe next slide. I'll just give you a small introduction on what we're doing each year on our annual impact report. So we are a social enterprise, and impact is very important for us. It's not a marketing gig. And as much as we do a financial report every year, we try to keep ourselves disciplined to also show what do we reach on impact. You can download it yourself later on. There will be a kind of a barcode you can scan, but I will just walk you through later on the main results. Next slide, please. So foremost, we are an official B Corp. That's a social enterprise. Always people ask us, well, what's the difference with a normal company? We also are for profit, but we are actually kind of a commercial NGO. We have the same mission, but nobody is funding us. And we are focusing very much, in our case, on eradicating tuberculosis and improving maternal care. So we also part of the United Nations Global Compact. There's also about sustainability and social response policies. We focus on the Million Lives Collective, that we try to improve the lives of people living on less than $5.5 a day. And here you see some recognitions, and that last year we were recognized by the for the Health Tech Awards, and on the Dutch Financial Times we were scored the best company on impact and innovations. So it was something we were very proud of, and my mother as well, actually. Next slide, please. So just to give you an insight on who we are for people who are familiar with Delft Imaging, we are in TB screening since the 50s of the former century, always supplying X-ray, analog X-ray. And it was until 2007, roughly, that we started with this artificial intelligence. And this eventually changed the whole market. So where we used to be screening with sputum analysis, together with X-ray and AI, we made it possible to introduce mass screening again, something that we did in the Western world in the 60s and the 70s of the former century, but wasn't possible if you don't have enough doctors. So the CAT for TB was our biggest invention. We started with stationary X-ray, but soon we noticed that the very remote areas, you really need something different. So we developed this backpack X-ray in 2018. And it was, I think it took us about 10 years to get the WHO convinced to endorse this solution, which they did in 2021. And then actually the roof came off. We had so many requests for this solution, and a lot of different companies were inspired to do something similar, which is a good thing because it will just only sooner eradicate tuberculosis. So at the moment, a lot of our attention is going into also ultrasound for tuberculosis. So we have this LAS for TB because we noticed that it's very difficult to screen the young pregnant mother. So LAS for TB is an important one, and we are very much focusing on pediatric, but I will say something about that later on. Next slide, please. So what's in the impact report? It has to be very transparent, and we should be accountable. I always find it difficult to talk about impact because it's so easy to make it a marketing item. So we very deliberately in this impact report show you how these numbers are formed and what they are based on. In general, we can say we screened 32 million people with our AI, and we are active in 85 countries worldwide. And it also means that we have service partners in 85 countries. I think that's a very important thing to realize. The total solution has to be X-ray and AI. And we were originally an X-ray company developing our own AI. so that we know how difficult it can be to do installations in the field, and therefore we train a lot of our service partners. At the moment, if you see on the right, the on-time delivery rate, which means actually if we say we deliver in April, then in 96% of the cases we are spot on time. If you have a technical inquiry, and that's an important one, we answer within 20 minutes, and we try to lower that every year. And the customer satisfaction is 4.8 on a scale of 5. And eventually also on the training, we had a very high feedback. But it's very important after so many decades of doing these kind of solutions. We know that buying the solution is one thing, but installing it, keep it up and running for a lot of years and keep everybody trained year on year. That's very important to keep the customer happy. Next slide, please. So this is actually what we did in this year as kind of improvement. So the Delft Light, we doubled the capacity. We saw that if you're in the remote area, it's frustrating if you cannot proceed. So instead of the 200 exposures we already did, you can now do 400 exposures a day. And we redesigned the backpack X-ray. So it's much more compact now, and it's much lighter. That's easier to carry around. We also improved the design so that you can do more multifunctional X-ray examinations. So not only for TB, but extremities or abdomen, that's much easier at the moment. They will talk later on a lot about CAT for TB, but I just will say what we have improved for this year on version 8, not only the specificity and specificity on the TB score, but also the abnormality score, if it's normal or abnormal. And for the people who have read the latest FIND report, it's you can be very specific of normal, abnormal, all these different features. That's easy to give false positive in the field. So we are at the moment more focused on the normal, abnormal score. But again, my colleague will eventually talk more about this. We have another very specific AI solution that's CAT for silicosis for the mining industry. And what I think is a very important one is LAS for TB, the ultrasound AI, because it's a totally different field. Point of care ultrasound can be huge, and we are investing in this already for more than 7-8 years. It's with a baby checker for maternal care and with LAS for TB to see if your chest is normal based on an ultrasound. So pediatric for us is an important new development. Well, new, we were working on that for a lot of years, but it's now introduced in our latest CAT version as well. Next slide, please. So it's easy to say that we have great products and we're doing well, but it's more important that our customers confirm this. And in the impact report, you see a lot of our established customers confirming what their experience was, and you can always contact them yourself to discuss what the experience is. But here are just a few out of the impact report. Some of them, like in Pakistan, we worked with them already for more than 10 years. Next slide, please. So not to take too much of your time, a lot, as I said, as a B Corp, we reinvest a lot of our money back into new innovation. The LAS for TB and the ultrasound AI is a very important one. But we also like to do some extra activities, and that's within the Delft Foundation, focusing on education and empowering women. And this year, actually for 2024, we focused on the Delft Imaging Coding Club in Ghana, where we teach Ghanaian children software skills and AI skills. And we also supported the UN RWA in Palestine. We are not politic. We don't do politics, but it's if people are suffering that much, we like to help, and that's what we did last year a lot as well. The last point we did with Delft Foundation was a charity ride where we impacted 100,000 residents in Tanzania. So we do this every year. If you have some ideas for your activity and it fits education and women and empowerment, please let us know. Next slide, please. So this is almost the last slide, the outlook for this year, reinforcing the case detection, supporting TB and also maternal health. We are strengthening healthcare systems. So despite the Delft Light, we have almost in total 10 different X-ray you can use, so stationary X-ray, Bucky rooms. So we can apply all kind of different solutions depending on your circumstances. We are focusing a lot on building the local capacity with our service partner. And everything we do is sustainable solar powered. We introduced that already in 2014. For us, it's so normal, but it's good to enforce it here as well. Everything is solar powered. And then with these kind of platforms, is what we do today. We like to share the knowledge we have and the experience. And again, as a last point, focusing on innovations, because that's the way to eradicate tuberculosis in the end. I think we have the last slide with the barcode. The next slide, please. So you can download the impact report yourself. And then I want to thank you all for your attention. And I hope you will enjoy the webinar. So back to Katja, please. Thank you.
Thank you so much, Guido. That was a really insightful presentation. Next, we have Dr. Bram van Ginneken. Next slide, please. So next we have Dr. Bram van Ginneken. He's a professor at Radboud University Medical Center, Nijmegen. And today he'll be discussing ancillary finding in TB screening with chest radiography. Next slide, please. The floor is yours, Professor Bram.
Hello, thank you. I'm going to try to share the screen. Do you see the screen?
Yes, we do. Yeah.
Excellent. So thanks for the invitation to talk here, and I'll talk about other things you may see in chest X-ray when you do tuberculosis screening. These are my disclosures and a bit of the background. In the slide that Guido showed in the previous presentation, it all started in 1996 with research. That was my PhD. I was hired as a PhD student, made the first version of what later became CAT4TB in the previous century. And it was eventually brought to the market in 2014. And I'm really proud of how widely it is used now. But I've been heading a computer-aided diagnosis lab at multiple universities, and I've worked also in other areas of AI in radiology. So I want to talk today about, first start with what is available currently for chest X-ray in the Western setting and how that is going, and then emphasize that TB screening is really a completely different setting. And then focus on attempts to identify other abnormalities in chest X-rays than just TB. Talk a bit about screening principles and focus a bit on one of the possible applications, lung cancer screening. So we have made a website in the Netherlands of all the AI products that are on the market today for radiology. And it's a nice website to go there if you want to see what kind of software is currently available. And there are already almost 230 products available, CE certified for AI in radiology. And here you can also choose different subspecialties. So if you choose chest X-ray, you see that there are now 31 products available that analyze chest X-rays. So too much to show all. But the trend really is, and I'm highlighting this here with one particular software program, to try to detect all abnormalities you can see in a chest X-ray. This is software from an Australian company that detects 124 different findings on chest X-rays. And where this is going is that these companies are now actually starting to also write the radiology report. And this is in a Western setting where there's a lack of radiologists and an enormous amount of chest X-rays to report on, something that could really improve efficiency. However, you have to realize it's not really there yet. We have done in our university group a study published last year where we looked with another software from Lunit, if it is possible to automatically write a report that a case is completely normal if the AI systems do not detect any abnormalities. Because then potentially radiologists will no longer have to look at these normal exams. But we actually found that if you want to not miss any abnormalities, you have to use a fairly low threshold, that you could only reduce the workload for radiologists by 15%. But still 15% is a good start. And I think slowly but surely, when AI would further improve, more and more chest X-ray exams in a Western setting would no longer have to be reported on by a radiologist. Given the shortage of radiologists, that's an important development. But going now to TB screening, you have to realize that TB screening with chest X-ray is a completely different setting. We're not looking at two views, we're only looking at a posterior anterior single chest X-ray. We don't compare to prior images, and in the case of TB screening, suspicion for TB is really the primary output of the exam. If you look at scoring systems that are used in TB screening, then very often the readers would also report cardiomegaly and the presence of other abnormalities, because if the person would subsequently test negative for TB, but there is an abnormality on the chest X-ray, you have to do further research to find out what's going on. But that's it. Although complex systems exist, here's an example of a system from Cape Town, where you can indicate all kinds of other abnormalities as well. In practice, these systems are not widely used. So you could actually wonder what the use is of detecting these other pathologies. But as I just showed, that there are now systems on the market that detect multiple abnormalities. Of course, people have started to test them out in the context of TB screening. And this is a recent publication that looks at 3 different packages and then draws the conclusion that the findings alleviate ethical concerns of missing abnormalities other than TB. And it would show their broader applicability. But actually, after reading this paper, I doubt if this is a conclusion that you can draw. But let's look at what they did. They took images without chest X-rays, without TB. It was from Germany, where there is very little TB. And then they looked at the other abnormalities that were present on these X-rays, and they let radiologists read these cases. So they indicated that these findings, these abnormalities, were present on a certain subset of these images. And then here you see the sensitivity and specificity of these 3 software packages that were analyzed in this study for these various abnormalities. And like I said, cardiomegaly, I think, is a useful one to report on. It's commonly done in TB screening. But if you look at the sensitivity, it's actually quite disappointing. 55% specificity, 97%. 47%, 51%. So this is something to be aware of, that if it finds a lot of abnormalities, for all these abnormalities, you have to wonder how accurate it really is. And in fact, we did a study a couple of years ago where we looked just at detecting cardiomegaly. And we also checked how well radiologists could do that. And on this data set, you see that radiologists achieve an area under the curve of 0.98, which means that they have both sensitivity and specificity in the around 93, 94%. Now, why do radiologists not have perfect result? Well, the cardiothoracic ratio, which defines cardiomegaly, you will always have borderline cases, right? The threshold is 0.5. So if you have a case which is just borderline cardiomegaly, one person will measure a little bit longer line than the other person. So you will always have inter-observer variability. But it's actually possible to do this with over 90%. And what you see here in the blue line is the result of our software, which is working just as well as radiologists if we actually find the heart and the lungs and do the measurements with the software. So we segment these structures and do the right measurement. But what most commercial software does is just take images with a label, cardiomegaly, yes, no, train a neural network. And what we show here is that you get, well, worse performance, but actually a bit comparable to what was done by these 3 other packages, around 50% with high specificity. That's the green line. But the segmentation method, we trained with only 600 images, and this green line was trained with 60,000 images. So it's much more difficult for a network if it doesn't get exactly the location of the heart of the lungs, but just the label to give good performance. And actually, I think therefore you have to be very careful if you want to find all these different abnormalities with a single network. But still, I mean, it is what these packages provide. And you have to realize also that for most abnormalities, you have either not too great sensitivity or not too great specificity. So if you run that on an X-ray, you will almost always find something, and it's actually likely to be a false positive. And you have to wonder, what would it mean clinically if you see a calcification on a chest X-ray? Well, actually nothing. It is something that a radiologist should report in a radiology report, but most of these things do not have a direct influence for a patient, maybe with the exception of pneumothorax, which is of course very rare in a TB screening setting, but actually the software is doing quite a good job there. Also, if you look at the relation between these findings by the different software and the actual diagnosis, well, in this paper, they also say that atelectasis is a diagnosis. I would not agree with that, but you see that there is a different relationship with it, but it is definitely not that you're immediately making a diagnosis. So I think this is important to realize. Because if you do additional things in a screening setting, you really should go back to the basics. And this is the old classical WHO study from the 1960s that talks about under what conditions should you do screening. And there are a couple of requirements there. You should only do screening if you're looking for an important health problem. There should be an accepted treatment. You should be able to treat the patients that you detect. There should be a latent or early stage, because if you detect the disease only when it is completely evident that it is there, then you can just as well not screen and wait until the patients go to the doctor. There should be a suitable test, acceptable to the population. And in the end, the cost of screening should be balanced with the expenditure of the medical care. So it's really cost-benefit analysis is very important. Otherwise, you're just going to find cases that should not be treated, and that is quite risky. So if we now look at an example of a disease that people are suggesting we could look for on X-rays made during TB screening, namely lung cancer, we can go off this list and see if it is really worthwhile to screen for that. And then actually you should first consider in your population that you're screening for TB, is there actually a lot of lung cancer available? Because really this is only prevalent under older people who have been smoking or are still smoking a lot. And that's not always the case in TB screening. It is the case, though, that lung cancer, if you detect it early, you can sometimes treat it. So there is an early stage that you could presumably detect. But then you have to realize that in a lot of countries where there's a lot of TB, there is not the possibility to diagnose and treat patients, because you have to do, in the end, a lobectomy, which is very advanced thoracic surgery that's not always available. And otherwise, you have very little to offer to people with potential lung cancer that you have detected. Moreover, chest X-ray is known not to be a good test for lung cancer. So CT, on the other hand, is a good test and is recommended, but the lung cancer, chest X-ray screening for lung cancer is not recommended. It will lead to a lot of false positives and necessary follow-up. Just to illustrate that, this is a CT scan, and here is a nodule. This could be lung cancer. This is something that you might want to detect earlier, but you see it very well on a CT scan. But if I make the slice of the CT scan thicker, this is 3.5 millimeters. If I've cut 3.5 millimeter, now it's already difficult to see this nodule. If I make it 7 centimeter or 10 centimeter, it's impossible to see the nodule. So this is why chest X-ray is generally not recommended. When you see a nodule on a chest X-ray, it's already bigger than this, and then it might actually already be a metastasized lung cancer, which is not curable. And that's really the balance you have to deal with in screening. On a simulated X-ray here, you really cannot see that nodule. As a result, the guidelines, this is a guideline from the NIH, really advise against using chest X-rays because it doesn't work for lung cancer screening. This has been analyzed in a very large study published in 2011. And they found that chest X-ray screening simply did not lead to lower death for lung cancer. On top of that, they have done a very big screening in the US with CT, and there it was shown that this actually works for lung cancer screening. But in that trial, they used a group for chest X-ray as the control group because they know that chest X-ray screening for lung cancer doesn't work. You have to keep that in mind. So I'm a bit skeptical there, and I think you should really be careful in interpreting the data. This is a recent publication from a study from Vietnam where they tried to do lung cancer screening within TB screening. And they showed that after screening 136,000 subjects, they detected people with malignant lung nodules, but in the end, only 133 were diagnosed with lung cancer. And that is 0.1%. Well, actually, in the lung cancer screening, it is common to find lung cancer in 1%. So this shows that within a group of people that you screen with chest X-ray for TB, you will generally find very few lung cancers. But of these 133, only 84 were treated. Presumably in the other cases, the lung cancer was already so far advanced that treatment made no sense. And what they don't report is how many of these 84 people, so 0.05%, were actually successfully treated in the sense that they had a good survival after this treatment. So I think we have to be very aware of that when we're going to find other things, that you basically should only screen for important health problems which can be treated, and if you don't cause too much harm. So most of these additional findings that this screening software could detect has no clinical relevance, and in fact, lung cancer screening with chest X-ray is not recommended in general. And given the fact that often treatment options are not widely available if in areas where you do TB screening, you really should only consider looking at lung cancer, in my opinion, if you know that there is a high incidence of lung cancer in your screened population and you have treatment options available. Thank you for your attention.
Thank you, Dr. Bram. So before I introduce the next speaker, I just wanted to go through some of the instructions that I gave in the beginning. So if you have any questions about any of the session that you hear today, kindly put it in the Q&A box so that we can answer them in the end of today's webinar. Additionally, for the people who have just logged in, this webinar is being simultaneously interpreted in Arabic, French, Spanish, and Russian. So in order to hear the webinar in the language of your choice, just click the interpretation button and select the language in question. Next slide, please. Yeah. So without much wasting more time, I'd like to introduce our next speaker. I'd like to invite Professor Rodney Ehrlich. Professor Ehrlich is a research scholar from the Division of Occupational Medicine, University of Cape Town, South Africa. Picking up from his presentation from last year, today he's going to be talking about CAD in silicosis screening, moving beyond accuracy to adoption. Next slide, please. Welcome, please. Rodney.
You can hear me clearly?
Yes, I can.
Yes, thank you. Yes, so my disease follows on quite, or the presentation about this particular disease, silicosis, follows on quite closely. Unlike lung cancer, silicosis is very associated with tuberculosis, which I think is one of the reasons that Delft have invested in silicosis, because there are similar markets, similar populations. And my perspective, there are two important issues. Aspects. One is that I'm an occupational health physician, so I look at it from an occupational health perspective, which is not always quite the same as a public health perspective. And secondly, I come from an area of the world where there are extremely high rates of tuberculosis and HIV, as well as silicosis. Next slide, please. My first presentation really talked about silicosis, the disease due to dust, and I don't want to repeat much of that, but to refer the viewers to the previous presentation, which is still online. And if you get this presentation, you'll be able to go via that URL. Just a few points about the use of CAD for screening or triage. That's what it's used for, not diagnosis. Further investigations, which would increase the sensitivity and the specificity, bronchoscopy, biopsy, are not usually feasible in the settings about which we are talking. Diagnosis is not purely radiological, but it really relies on the acidic exposure history, competing diagnosis. There is no single gold standard test equivalent to GeneXpert. Experienced readers are needed, so it doesn't really mean a lot of radiologists will not have had experience of silicosis, and you really need readers who may not be radiologists that have such experience. For example, in the mining industry, those who have made this area their specialty, and often there's a panel because there's a lot of inter-reader variation. It fails one of the key tests for screening. It is not a treatable disease, and we'll come back to that later. The CAD output, there's no heat map at the moment. It is a numeric output on the 0 to 100 scale. Next slide, please. Oh, so accuracy. So accuracy is a requirement for utility, in other words, for practical applicability that does the things that we heard from the first speaker. It's based on correspondence with the reference standard, which I've just mentioned. It depends on validation and calibration studies. We've done some, and you'll find those online. And it requires at the point, in order to proceed, a choice of threshold. And most people that I've come across when talking about the use of CAD don't really understand the concept of the threshold. Readers use the International Labour Organization classification of pneumoconioses. The CAD is, in a sense, a black box, and silicosis positive depends on where you set your threshold, and often people struggle with that. So they have problems perhaps with interpreting accuracy, but our point of kickoff for this talk is assuming you have an accurate system. What next? Next slide, please. The introduction of CAD for the use cases, and I'll talk about some of them as we go along, a number of them, immediately raises the question of cost. And I just put this there because in making the case for silicosis, often that is the question in your listeners' minds. And there are a number of aspects to the cost. There's the equipment and the software, there's the maintenance, connectivity, and the choice there would be between cloud and local solutions. Delft is heavily invested in local solutions, not requiring the cloud. Data management, that's a capacity issue, storage, and also the data security is in the modern world increasingly important. Staff time, there's the training of perhaps medical officers or clinical assistants who are turning over, and the health system has to be able to put its own staff into these settings. And then the cost of referral and confirmation by experts alluded to, for example, in following up nodules for lung cancer. In this case, it's not for a sputum, which, for example, could be done on site, but almost certainly referral to experts who are sitting elsewhere. It's a question of what can be transferred to them and what requires the patient or the participants traveling is an important one. So that's the question of cost. We now move on. So adoption, again, people don't quite get it. And I think what I'm finding is that a lot of the attention up to now in the literature has been paid to accuracy and surprisingly little attention to this phase, as it were, of utility and benefits. So efficiency is the one can certainly be shown. There's a lot of evidence for that you are able to lower the costs of the current practice program. For example, fewer referrals for negative chest X-rays if you have an accurate system. And most systems are now fairly accurate, in other words, sensitive with regard to excluding chest X-rays for silicosis. Effectiveness is where there's, again, some misunderstanding, which really asks the question, are the outcomes better than outcomes? We're now talking about medical and survival and morbidity, mortality outcomes better than are currently available For example, where there's silicosis screening, there is no doctor. In other words, the default would be no screening. There's a misunderstanding, for example, that at last he has a system which can do better than the doctors for silicosis, because it's well known that doctors often miss silicosis, medical practitioners. That is not the case, because that's built in, certainly for expert readers, that's already built in the process of training the CAD based on human readings. So really the use case is the basis for deciding the utility, and there are a number of use cases which I'll talk about, but really the sort of iterative process is the same, that the user, perhaps in collaboration with the vendor, has to decide on the optimal balance of false negatives, that's missed disease, how much does it cost to miss a disease, reputationally, and with regard to medico-legal exposure, and ethically. And false positives, often it's not seen as a greater priority, but in fact they can impose significant costs of referral and investigation for participants who do not have the disease. So just to emphasize the threshold, if people ask what is the threshold for the system? No, these are the potential users. You tell them, no, you have to establish the threshold. They find that quite daunting. Next slide, please, but it's an essential step. Next slide. So the next step that people find surprising, besides having to decide the threshold, that actually the decision depends on something that's well known in clinical epidemiology and predictive science, is the positive predictive value. And that is not this, and its counterpart, the negative predictive value. So sensitivity is of those that are truly positive, how much does the system, the AI system, pick up? This reverses it. Reverses it quite fundamentally. Of all those determined or assigned as positive by the CAD system, what proportion would be confirmed by the gold standard, in this case, the human reader? And it's a law of positive predictive value, that the less common your disease is, and people who've done public health and clinical epidemiology will understand this, the less common the disease, the poorer your positive predictive value. So here are three use cases in my own setting. The first was in employment, screening of minors. They're looking for new cases, so not cases that are known. And in fact, given a decline in silicosis and the shrinking of the workforce in South Africa, the proportion of new cases that would be picked up in annual screening is actually very low, 0.3%. Threshold of 39 is imported from a study that we did. In that particular case, with that threshold and that prevalence, the positive predictive value would be 1.6%. The negative predictive value would be 100%. So if the system is able to assigns a chest X-ray as negative silicosis, it's almost 100%. That's very useful. However, if it assigns positive, almost all of those cases going through for confirmation will be found not to have silicosis. That's a substantial cost. And see why it's important for workers as well. I'm going to jump to the last one. I don't have to spend too much on each slide. In the adjudication setting, this is where claims are submitted to the compensation authority. The pre-probability of having silicosis is much higher. They've already been screened. Somebody has identified that there may be silicosis on a chest X-ray. And here we have a prevalence of incoming claims of 25%. Same threshold. The system doesn't change. It's not dependent on the CAD system. It's dependent on the use case context. Here, the positive predictive value reaches 63%. Now, that's much more useful. The negative predictive value is the same. Exclusion means the silicosis is not there. Here, it means that, in fact, in two-thirds, as high as two-thirds of the cases identified by the CAD will, in fact, have silicosis, and that's quite useful. So this is part of the journey that the user has to do. Next slide, please. So we're thinking laterally because we're looking for other applications or other ways in which the CAD can be used. So the focus has always been on one threshold, a binary system. But in fact, because particularly in the compensation system where there's a lot of triage required, thousands of cases come through the system. The backlog 5 years ago was 100,000 claims hadn't been dealt with. CAD is clearly being seen as a way to reduce the load. And the load is actually medico-legally driven, that in our compensation system for minors, you need the director, that's one doctor, 3 other doctors in the panel, and a radiology reading. That's a very heavy staff and expertise load. So you can see that CAD could improve efficiency. And so a lot of the time, because of the interreader variation and the difficulties of distinguishing silicosis and tuberculosis, is spent on the zone I call the zone of uncertainty. And that's actually the middle zone. So this is a two-threshold model with CAD scores distributed along the x-axis from 0 to 100. There's no, it doesn't come with its own threshold. I have to emphasize that. You have to put in the thresholds. And from the system, the study that I've been drawing on, we choose two thresholds. It's based on a choice of NPV and PPV, but let's say 12 for the lower threshold and 78 for the other threshold. So this creates what we call a zone, combined zone of high confidence. If the threshold is below 12 and the CAD identifies a negative silicosis, it's almost certainly negative by confirmation. In fact, there's only one exception. If you look at the shading, that's the little black histogram. For the upper threshold, it's a little smaller. There are fewer positives, but in fact, the CAD using this particular threshold is able to identify correctly most of those positives, and you can see there are only 4 cases with the cross-hatching in the last zone. The middle zone is unclassified. Now the question is, do you want as many referrals, or do you want to bring the thresholds in order to reduce the number of cases going through to the, say, major confirmed panel, but at a cost of more false negatives and false positives? So this is really, if you haven't got it at one go, please have another look at the slide. This is the type of calculus that would face the user. So ultimately, it depends on the cost versus utility as seen by that user, in this case, the compensation authority, which is underfunded and has to reduce its use of doctor time. Next slide, please. Previous Bram, if I can call you that, has been through this. This is the well-known principles of screening. It must be manageable or treatable, detected in an earlier stage, and that which the individual present. And in this case, it's used for triage, identify those with more likely to have the disease for priority investigation. That's in addition to screening. The pitfalls are, as we've gone through actually in both presentations, where there's a low prevalence and suboptimal specificity. In other words, specificity is not 100%. You're going to have low positive predictive values such that most referred cases are not going to have the disease. In the occupational setting, there's cost, there's distress, and problematically, there may also be job loss. I'll come back to that. The adverse effects of investigation is not merely the trouble, the time, and the distress, but biopsies have complications, usually infection, but mainly nerve damage, and unnecessary or expensive imaging. People, for example, have to travel to a central hospital or regional hospital where there's a CT scan, if there is one in the country. The benefit to cost ratios for all screenings may be different from the individual, particularly those who have the means to pay for it, and community or institutional perspectives. And often people don't understand, particularly people who are privileged and have medical insurance, that screening for them is not the same as a screening program for a whole community or a country. Next slide, please. So we come back to silicosis and the benefits of screening and triage. Let's start with current workers. That's the one where there aren't that many new cases coming up, but the mining industry is certainly interested. They've been sued, they have litigation, they're shrinking. I'm talking about gold mining, where the rate of silicosis, the risk is very high. So early detection, what's the point? There's no treatment. However, there is a point. In the occupational health setting, the purpose of early detection of occupational disease is to say that the employer can commit themselves to making the investment and reduce dust. Simple as that. The pitfall is the screening, but no action. And employers struggle with this, and even employees if there are job security issues. And we're talking about the range from multinational mining organizations that have a reputational risk to informal or small-scale miners, of whom it is estimated there are currently about 45 million worldwide, not all exposed to silicosis. If you took it half that, and many of them are working in high TB settings. So talk about the employer investing in dust control can't mean the same thing there if there is an employer. So that is something, certainly a potential. there used to be a medical belief or maybe a medical legal requirement often that an employee diagnosed with silicosis has to cease exposure, which usually means ending their job to avoid progression. Now, there might be some truth in that for certain people, but the basic the reality is that people can't afford to leave work. Often the disease is not highly progressive. The major risk is getting TB. And there's not strong evidence that leaving work, if they've already been exposed to dust and have silica in their lung, averts the TB. Just might come after employment, which actually puts them in a worse position if there's medical care at employment. So pitfall there, unnecessary job loss. Screening workers more regularly, and that makes sense occupationally, but particularly for those who have the genetic predisposition and other factors we don't understand for regular progression, and particularly to TB. This needs an evidence base, but it's a hypothesis worth testing. Last slide, please. So now we bring together the value of screening for both current and ex-workers. So a big question, and a lot of people, of course, in the TB world are highly committed to, is to treat latent TB infection and the reduce of risk of TB. So certainly it remains a hypothesis, but actually a hypothesis for silica-exposed workers and those with silicosis with regard to effectiveness, not efficacy. Do these programs work? And in fact, the studies that have been done show that in many settings, the effectiveness is not great. And the problem of poor adherence and high adverse effects with certain TPT regimens is actually quite high. Here's something that really is not taken into account in the TB world. So the silicosis and TB worlds are mainly split. Most people, this is a complaint, most people in the TB world do not have an interest in silicosis, only really those in places like Southern Africa, India, perhaps China, Indonesia, others increasingly so. Silicosis may impair, and there's good evidence it does, the response to TB treatment and lung recovery. By lung recovery, I mean the post-TB lung damage and fibrosis. It's now the focus of considerable attention to see if there's anything that can be done about that. And one of the problems for CAD is that the two diseases look alike and they can occur together. So it's a double whammy. The one may be the other, the one may look like the other, but in fact they may both be there. And that is proving to be quite a severe test for CAD accuracy, which is something we're working on. And the last point is something that is probably one of the drivers, certainly in the industry and in Southern Africa, determining eligibility for compensation. This is now later in the disease when you have enough disease for compensation. It's really too late in a way for any, in the preventive sense, and given it's a slow developing disease. Silicosis and silicotuberculosis can occur in any stage once you've had silica. This requires very high sensitivity and panel confirmation that we found for the CAD, and that's something, of course, that we're working on and hopefully be using quite soon in the Southern African context. Thank you very much.
Thank you, Rodney. That was quite a riveting presentation, especially I think the ethical conundrums around, around silicosis detection was quite fascinating. Without wasting further time on my end, I'd like to invite the next speaker, Professor Helen Ayles. Professor Ayles is a professor of infectious disease and international health at the London School of Hygiene and Tropical Medicine, University of London, and the director of Zambart. Today, she'll share insights on the Ubumi Bwandi Ubumi Bwandi project, her topic being screening more than TB. Next slide. The floor is all yours, Helen.
Thank you very much, and good morning or good afternoon to everyone. So I'm going to change it up a little bit and describe a project that we're doing here in Zambia. Although it says I work for the London School, I'm actually based full-time in Zambia. And we are conducting a project under the Stop TB, TB Reach program called Ubumi Bwandi, which is all about how we can integrate screening and prevention with screening for TB. Next slide, please. So I know many on the call are experts in TB, but I just wanted to really bring out a few of the key issues from last year's global TB report from the WHO. 8.2 million people were diagnosed with TB in 2023, and that's the highest number ever. And while deaths are falling, incidence has increased. TB has once again taken the top spot as the most important infectious cause of death worldwide, and we're really not on track to end TB. And so we really need to think harder about how we screen TB, how we prevent TB, and particularly in high burden settings, such as South Africa we've been hearing about, but also in Zambia. Next slide, please. So Zambia is one of the 30 high burden countries worldwide, and our TB incidence nationally is 307 per 100,000 population. Zambia also has a very high incidence of non-communicable diseases, and TB, along with HIV and malaria, has had more external resources poured into it, whereas actually for non-communicable diseases, these resources have been less, and so services consequently have been more challenging to provide. I also think that in most lower middle income countries, places similar to Zambia, our health services are pretty overburdened, and they've been focusing on diagnosing and treating the sickest patients and really don't have an awful lot of time for screening and prevention of all these other diseases in their populations. We've heard a lot about screening and screening guidelines, and there are many diseases for which timely screening can provide a chance for early diagnosis and treatment. So we set out to try to integrate screening and prevention services for TB and non-communicable diseases in this project. So next slide, please. Just to give you a little bit of background, we did this project in one community called Chipulukusu, which is in Ndola on Zambia's copper belt, which is one of our mining regions. And it was a population of about 50,000, a population where I've been working for over 20 years, and in that time I've done 2 TB prevalence surveys and noted that the prevalence of TB was really high and not declining. So felt we really needed to try and do something to see if we could reduce the prevalence of TB. So next slide, please. I apologize that this is quite busy, but it's trying to show you all the different services that we integrate. First of all, we wanted to bring screening close to where people live, and recognizing that there is one health facility, government health facility in this community, but it's already very busy dealing with people who are sick. We decided that for wellness screening in people who are currently well, we needed to set something up in the community. So we developed something called a community hub, and I'll show you a bit more about that in the next slide. But in that community hub, we invite the whole community to come through, with our aim being to offer screening to everybody, at least annually. So that includes an annual chest X-ray, but also to provide other screening. So for HIV, sexual reproductive health, substance abuse, provide nutritional support, obviously TB screening, screening for other non-communicable diseases, such as measuring blood pressure, for screening for diabetes, providing information on common cancers, breast, cervical and prostate cancers and testicular cancer, and cervical cancer screening, and also provide healthy living education. We refer any individuals with conditions that need further management to the healthcare facility. And in the facility, they also do a similar screen to what is going on in the community hub. Next slide, please. So what did we do in the last year of this project? First of all, we developed this community hub. Actually, this is a building that belongs to the local council. It was a very derelict abattoir. You can see in the top picture, the image on the left, half its roof was missing, it was leaking, it was very run down. So we renovated that to become a community centre where a lot of other activities can take place, including community gardening, sports, various clubs, but also to be this community screening centre. We set up a chest x-ray machine with the help of Delft, both at the clinic, and that's the picture at the bottom. You can see the x-ray machine in the clinic is in a containerized setting. It's got solar panels on the roof. And also we have one of the portable chest x-rays at the hub. Everybody who comes through, we've given everybody in the community a card called an Ubumi Bwandi card, and it's like a loyalty scheme like you would have in a shop. So every screening or preventive activity you take part in, you can earn points, and you can then redeem these points when you earn enough of them for a reward. Next slide, please. We also had to employ some additional staff, particularly radiographers who didn't exist before because none of our primary health clinics in this region had a chest x-ray before. All the laboratory support was through the laboratory at the health facility. And we also did some outreach activities in other parts of the community, and you can see a portable x-ray being used here. We also partnered with many other organisations providing services such as mental health support and also eye screening camps, which were incredibly popular. Next slide, please. And just to give you a little snapshot of the services, the total number of adults that we enumerated in this population was just under 40,000, and about a quarter of them voluntarily passed through the hub or the clinic in the period that we were operating. And most of them had a chest x-ray screening for TB. And just to show you a bit more data on the next slide, again, it just really shows how many people, sorry, that hasn't really projected very well because there's quite a bit that comes off the bottom. Don't know why that's happened. But anyway, just to show that most people were screened with the chest x-ray, a proportion had an HIV test, and most people had a blood pressure check. Next slide, please. So our TB screen consisted of asking people about symptoms or having a CAD score of more than 50. And by doing this, we increased the number of people diagnosed with bacteriologically confirmed TB in this community. And we had a comparison clinic nearby, so we could also compare over time and compare with a comparison clinic. And we've shown a statistically significant increase in the number of people diagnosed with TB. We also found that a large number of people started TB treatment without bacteriologically confirmed TB. And most of this was based on X-ray. And of course, we also recognized that there were no alternative algorithms for other lung diseases in place at the moment. And so I just show you this chest X-ray. This is a man who's 45. He's had a history of TB in 2018, and he came with a cough and some chest pain. He is a smoker. He's HIV negative. He works in sand mining, so he has multiple risk factors for lung disease, but his sputum was negative for TB. And so the question really for the clinic, they would like to put him on TB treatment because they say this X-ray is abnormal, but probably he's got a degree of post-TB lung disease. Next slide, please. And just to show this to you in numbers, again, I'm not going to go through all these numbers. This is a slide that we presented at the union meeting last year. But when we screened those almost 9,000 individuals, about 900 of them were recognized as people who had either symptoms or chest X-ray signs that could indicate TB. We managed to collect sputum on 644 of those, and ultimately 224 were diagnosed with tuberculosis. If you can click again, please. But that left 420 people who had either symptoms or chest X-ray changes who were not diagnosed as TB. So what did they have, and were they given any treatment? What happened to them? Next slide, please. So what we decided to do was to apply to TB Reach for the next wave, which is wave 11, with our project called Ubumi Bwandi Pantanshi, which means my health, my choice going further, to really focus on how we can integrate lung health screening into this model that we've already got. To look about better diagnosis for pneumonia, for post-TB lung disease, for chronic obstructive pulmonary disease, and also industrial lung disease. We also wanted to improve our services based on the lessons we'd learnt last year and work a bit harder on prevention of lung disease. We see a high proportion of smokers, and so we wanted to set up a smoking cessation program and also expand TB preventive therapy. We also received some additional money from Bristol Myers Squibb Foundation to start looking and giving information about lung cancer in this community. Next slide, please. So this is the same diagram I showed earlier, just a bit more colourful. And in this one, the areas in red are the new things that we're adding. So it's mostly around lung health screening, but also working with the occupational health services in Zambia. There's the Occupational Health Institute, who are mandated to do screening for minors, but to work with them to do more outreach for ex-miners, people in the informal sector, stone crushers, cement workers, and also to set up respiratory clinic, which didn't exist at all in this district, at the secondary care level, where we can also do further investigations and spirometry. Next slide, please. Just going to show you our proposed algorithm, which again starts the same way, where we would screen with symptoms and the CAD for TB. Those individuals who are positive on that screen have an expert test done, all of them, and also a point of care CRP test. For those people, I'm sure many of you know this, but this stands for C-reactive protein. It's quite a non-specific marker of infection, inflammation, but it can be very useful in diagnosing bacterial infection. And we can do it on a finger prick point of care. Obviously, those individuals who have a positive expert, we can refer them to the clinic immediately for TB treatment. But for those in whom the expert is negative, which is the majority, we are going to use the CRP result to do a further triage, so that if somebody has a high CRP, we can give them antibiotic therapy for presumed pneumonia and review them. For those who do not have a raised CRP, it's unlikely to be bacterial pneumonia. And in that population, we will do some lung health screening and also get occupational history and refer for spirometry and also further assessment and management. Next slide, please. So what are the opportunities for lung screening beyond TB and also beyond chest X-ray that we're going to try and put into this project? As I said before, we're working with the Occupational Health and Safety Institute, who are mandated to screen minors, but to explore with them the role of CAD for silicosis in Zambia. And so we just heard from Rodney about the situation in South Africa. We have lower rates of silicosis in Zambia, but we still have many miners and many people exposed to harmful dusts. We're also expanding to communities employed in the informal sector, informal mining, stone crushers and sand miners, alongside OSHI. We're establishing the respiratory clinic, where we're going to be doing conventional spirometry and thinking about whether there's other ways we can look at spirometry, and setting up a respiratory rehabilitation service for post-TB lung disease. At the teaching hospital, we do also have access to CT scans, although they are costly and there is limited availability because they frequently break down for anybody who's suspected of having lung cancer or complex patients where we feel we need better imaging. And we're also incorporating lung ultrasound, which Guido mentioned right at the beginning, as an alternative to chest X-ray in screening for lung disease. We're doing this at the community hub, really seeing whether we could use lung ultrasound in this way in places where there is no access to chest X-rays. Next slide, please. I think there's also opportunities for continuing medical education. We're very proud of our virtual chest X-ray meeting that we have every week, where the radiographers present the patients with high CAD scores. And we have respiratory physicians from all over the country, from the main teaching hospital, ID specialists such as myself. We have the clinic staff. We have people from the Occupational Health and Safety Institute who join, and we all discuss the X-rays and we all learn from each other. And I think also we're starting to see the benefit of having annual x-rays and repeated x-rays. So again, this is x-ray of a 40-year-old gentleman who came last year, and his x-ray was the one on the right, and you can see it looks pretty normal and the CAD score is 6, and he came back only a couple of weeks ago for his repeat annual x-ray, and you can see he's now got what looks like consolidation up in that right apical upper zone, and apical region has a CAD score of 85, and his expert was positive for TB. Next slide, please. So I just want to thank all of the funders, all the people at Zambart and in Ndola, particularly the community who guided us in what they wanted to see being screened, and I look forward to any questions and discussion. Thank you very much.
Thank you, Professor Ayles. This was very fascinating to see how Zambart is working and just to see screening in action. Moving on, last but not the least, I'd like to invite my colleague, Edwin Klinkenberg. Edwin is a technical physician and a clinical application specialist at Delft Imaging. Today, he'll be talking about establishing trust in emerging AI technologies. The floor is all yours, Edwin. Next slide, please.
Hi, hello. Can you hear me clearly?
Yes, I can.
All right, very good. Hi, everyone. Thank you, Katya, for our introduction. So today I'll be discussing some topics about establishing trust between the new and emerging AI technologies and how you can really do that yourself as well. So next slide. So I'm discussing really this topic because the integration of AI technologies in healthcare is really rapidly evolving in the last couple of years. And I think it's really crucial for all healthcare professionals to understand how to evaluate this new AI that come to the market. So my role also as a technical physician within Delft is also to ensure that the AI models fit within really the clinical practice and really can be used to solve problems and affect the clinical outcome. So today I will be sharing some insights on the evaluation of emerging AI technologies, and also share you a little bit about the journey that CAT4TB has done to really put it into perspective. We can go to the next slide. All right, so it will be 3 main topics. So some practical considerations for integrating new AI solutions, also going over some of the topics that Bram really discussed. Then secondly, reviewing evidence for new AI solutions, some tools for yourself, so everybody can use to build a trusting bond between you and the AI. And then CAT4TB, a decade of building trust. Next slide. All right, so first start off by the practical considerations. Next slide. And I think that for yourself is really, you have 3 main questions that you have to ask yourself when you see something that might be interesting. And first off, and also Bram really looked at this, is the modality, or in this case often X-ray, the right modality to use for the disease? Because AI is just an extension of the modality used, some limitations and challenges that initially apply to the X-ray, for example, would also apply for the AI. So for example, if you had an AI that would actually try and do a diagnosis of asthma, you could have to think like, is X-ray actually the tool that you use to make the diagnosis asthma? So you have to take this in consideration. And secondly, and I think this is really important, is where do we put the AI in the patient journey? So for CAT4TB, it becomes quite clear that we put the AI before the confirmatory test, in which we send people with a high CAT4TB score for a gene expert, for example, and let the others go back home. How does the new AI really come into play when we put it into our screening program? And that's where the third point comes in. What do we do with positive cases? I think it's very important to have a clear plan for managing positive AI results, as it includes determining the next steps. Are there additional diagnostic tests, referrals to specialists, and treatment options? So there's all kind of logistics around it that you might have to organize if you have a positive case. Next slide. And taking really everything into account, we really want to focus on 3 main topics, because we're in the screening program. So we want to keep it simple. We want to have actually an increased performance of our AI. And we also know that radiological features are not really diseases. Next slide, please. So really how our approach of CAT for TB is currently is that we want to keep it simple. So we have 3 scores, which were already shown by one of the previous, by Guido actually. First one is the one that we all know is the TB score. So it's trained on a bacteriological reference and really predicts whether a patient will test positive on a bacteriological examination. And secondly, we have the abnormality score. It's trained on a radiological reference and includes and detects lung field abnormalities. This also includes effusion, atelectasis, pneumothorax, nodules, and much more. But we really put this all into one abnormality score. And lastly, we have the cardiothoracic ratio, which indicates, of course, cardiomegaly. And we really combine all these 3 scores because we know that in a screening setting, overloading patients or users with information also affects and complicates the whole patient journey. Next slide. Yes, and I think Bram also shortly touched onto this, but I got actually a different article to show it. And I think also this is what we see with most AI now in the field, is that we see an increased performance if you look for general abnormalities. So combining everything into one score actually. And we can see that also here in where we have an increased performance compared to the other nodule opacity and pleural effusion detected by this specific AI. Next slide. And lastly, and I think this is indeed also very important to consider, is that diseases are really something different compared to the radiological features. In this sense, a radiological feature could help diagnosis of a disease, but are very often non-specific. So in the case of consolidation, for example, there are a lot of diseases that actually show and have consolidation in a chest X-ray. However, having consolidation does not mean that we have to treat the patient for this specific thing. It could still be something that does not have to be treated, or we could have various different treatment options. Next slide. So I think we really want to be careful, and we really put an emphasis on that we are in the screening setting. And I think this is really important because every false positive that we do send through actually wastes resources. And we know that we're in a resource limited settings. This does also affect the amount of people that you can reach. So we want to focus really on outcomes and AI that impact the patient treatment. Next slide. All right. So, but still, we are also generating new AI and much more AI are coming to the field. So I also want to give you some tools about how to review evidence yourself and see if it actually matches your patient population and your setting. Next slide. So first off, and I think, reviewing articles can be very daunting, but this are just some easy tricks to see whether the results would actually also be applicable for you. And that is really to look at the authors. So who are the authors? Who wrote it? Can we see from what institutions they came? And are there any conflicts of interest, which should often be declared in a paper? And one also important thing to note is that we also have to look at peer-reviewed articles, where the content of the article is often reviewed by other independent researchers. Next slide. All right, and I think this is from the same paper that also Bram showed. And I think we have to always look at what population they use for their study. And can we also apply it to our own setting, or do we have to take that into account when we interpret the results? So this study was conducted, for example, in a low TB burden country, Germany actually, and they only used abnormal chest X-rays included in the study. So taking these 2 factors into account, does it actually apply to the screening setting in which we maybe want to use the AI? Next slide. And lastly, I think we also should always look, of course, at the results. I think that, people can often say, look, our AI works very great, but you really have to keep looking at the numbers. And in this case, we always have these 4P statistics. I think most of the people know sensitivity and specificity, and these are almost always provided. But I think, as Rodney also said, is that the positive predictive value is also very important to really see what kind of impact an AI would have maybe in our setting. So as a result, as an example, in this paper, you can see that the nodule AI has quite an all right performance regarding sensitivity and specificity, both higher than 85%. But when we look at the positive predictive value, we only have 11%, meaning that if you have 9 people who test positive on a nodule, only 8 out of 9 of these patients will actually not have a nodule in the chest X-ray, meaning that you would only have 1 positive case and 8 cases actually maybe wasting resources during a follow-up. And I think we should really take at these numbers to look at how it will affect maybe our setting. Next slide. And I think besides really delving deep into the research, we should also look at the manufacturers. So for this example, also Delft, as we also have are responsible by providing our users with information. And we often put these in these extensive manuals and to give it a user-friendly experience to look at how the product is used, but also what limitations and contraindications are also there. And I think that if you want to use a new AI, you should always approach the manufacturer and ask the use cases and the limitations of the product. Next slide. All right. And also, let's go to the last chapter where we really also compare and see how CAT4TB did in this space and how we actually build trust with our users and with the WHO over the last decade. Next slide. Thank you. CAT4TB really started already in 2007 with its first prototype, meaning that it already started over almost 20 years ago with its first implementation in 2011. CAT4TB was CE certified in 2015, but still it took 6 more years before the WHO endorsed CAT4TB screening, meaning that it takes a lot of time before we actually know whether a product is really working in all different kinds of settings. But not only time will do that, but also really a variety of different publications. Next slide. So for CAT4TB, there are over 110 papers published in peer-reviewed journals, not only from one country, but all over the world. In at least 25 different countries have validated and published independently also about CAT4TB. The product has been used in various types of screening settings, for mass screenings, prisons, migrants, but also from active case findings, and tested in various comorbidities. So we know that this is not only working with patients without HIV or diabetes, but it's working in a diverse patient population. And I think this really gave also the WH the trust that the CAT4TB screening could be entrusted and recommended. Next slide. And lastly, I think it's also our job, and I think we also really proud ourselves to transparency. So as Delft, we also try to be as transparent as possible, and we also do this with the following topics. So we try to maintain research independency as much as possible. So independent researchers publish about our limitations, but also about our strong points. We promote and share these independent studies, highlighting both strengths and limitations, and provide users with easy access to the evidence. So you really can ask any of my colleagues for a paper whether it matches your screening setting, for example. Well, we organize these kind of webinars to support knowledge sharing, of course. And lastly, we offer a service where user can also test the product and see if it also performs according to their standards in their own patient population. Next slide. So really to conclude is that CAT and Delft really pride itself on careful implementation to really ensure benefit. we promote external validations and think that research is very essential before adopting a new and emerging AI. And in general, we think that transparency in good clinical practice should also be maintained by manufacturers. Next slide. All right. Thank you, everybody, for coming. And then I'll pass on the word to Katja again. Thanks.
Thank you. Thank you so much, Edwin. This was very insightful, especially from an organizational perspective. Next slide, please. Yeah. Now I want to welcome our Managing Director, Florent Geerts, who will be moderating the Q&A session. Florent, you can take it away. Thank you very much.
Thank you, Katja, and thanks everybody for joining today, and to our speakers. We've had about, I think, 300 people, almost 300 people joining which I think, especially in these turbulent times where we have a lot of things on our mind, it's really shows that it's a topic that deserves quite a lot of attention. We had a lot of questions on whether people get the recording or the presentation. So if indeed our speakers also give their permission to share it, everybody will get the recording who registered. And also we had quite a number of questions. So if you're not familiar with our format yet, what we always do is we try to pick a couple of questions live, and the ones that we are not able to answer, later you will receive a Q&A sheet that will have the answers to all of the questions that were raised. So if yours is not picked live, at least know that later on you'll get the recording as well. So to look at some of the questions, so there was a question from Daniel saying, okay, what is the possibility of finding TB and other lung diseases combined, and how does AI address this? And I thought it was a good question because it gives me a nice opportunity to kind of summarize what our different speakers touched upon. So I think we saw from Professor Bram, I think the option that CAD is good in splitting the abnormal and the normal part, and also that level of caution in looking at other elements, for example, like lung cancer screening, and the considerations for those kind of applications. Professor Rodney, of course, touched upon silicosis, of course, closely related to TB in its setting, and the possible combinations to apply AI there, and also the considerations there applicable. And Professor Helen also touched upon how they are looking to go beyond TB and to expand into lung health within their activities, and also the proposed algorithm even that they are looking at for that. And of course, that Edwin touched also upon different points in this regard. So I think that hopefully we've been able to show different perspectives here of what's possible, and the considerations and the limitations in that. And to pick out a couple of other questions, so there was one I wanted to ask to Professor Rodney perhaps to comment on, which was a question from Didier asking how accurate is AI diagnosis for silicosis and disseminated TB? I don't know, Professor Rodney, whether you can give your comment. You've done quite a lot of research.
So can I clarify the question? Do you mean silicosis plus disseminated TB?
Yeah, indeed.
In other words, silicotuberculosis, yeah.
Yeah, indeed.
Well, we've got good evidence that if someone's had previous TB, the sensitivity of and specificity, particularly of the CAD for TB declines, and this is well established in literature because they sort of they look like each other. I think the principle is, and this actually struck me when listening to Helen's presentation, that people who present with TB in a high silicosis or where there's a reasonable prevalent silicosis, such as the copper belt, it may not be possible to see the silicosis, or one might attribute nodulation where there's also disseminated TB. So really what should be done there, if the diagnosis of TB is made, they should be brought back. Assuming that there was some nodular abnormality on the X-ray. I'm not talking about a pleural effusion or sort of pneumonia in one lung, brought back, because silicosis, really, you want to make the diagnosis after TB has been treated because they can be confused. I hope that answers the question. But silicotuberculosis, even with old TB, definitely results in some fall, not dramatic fall, in the area under the curve. In other words, there is a decline in accuracy. And it's very interesting seeing how the CAD is reproducing the frustration of human readers in distinguishing the two diseases. Thank you.
Perfect. Thank you for that, Professor Rodney. Then there was a question that was, I believe, touching upon lung cancer screening through CT, and this is something I wanted to raise with Professor Bram. And I think the question was touching upon, in poor resource settings, as it was referred to in the question. CT is, of course, limitedly available, and then, of course, chest X-ray is more extensively available, although indeed you've mentioned a lot of considerations in this regard. How should people look at that? Of course, we know CT is the recommended modality to look at, but if that's not available, is it not better to leverage what is there, considering its limitations? Or, of course, are we then overburdening the healthcare system with chest X-ray, or not considering the treatment options enough? And should we therefore disregard that as an option at all? How do you look at that?
Yeah, I think it's really difficult. Depends on the local context. I think the main thing before you're going to screen for lung cancer is that you have your treatment in order, because it's also not just a CT scan and then you have a lung cancer diagnosis. You would typically do follow-up CT scan, see that a nodule is growing. Then you would do a biopsy to get a definite diagnosis. And then you could do surgery. But if it is difficult to obtain a biopsy, which is often done CT guided, so if you have no CT, can you do a biopsy accurately? And then you need pathologists who can look at the biopsy. And then you need thoracic surgery, which is complicated. So I think even in countries, in Western countries that are now considering to start lung cancer screening with CT, many countries do not have the treatment facilities in order. Only specialized centers would be well able to do that. So I think it is really the whole chain you have to look at, and it's sort of a healthcare system problem that you have to solve in order to set up a lung cancer screening program.
Yeah, clear. And I think sometimes in the discussions that I've had with people on this, and we touch upon this, people say, simply put, isn't it then still better at least to know the burden of the problem? So we're finding things with chest X-ray and potentially with CAT. Isn't it better than at least we know what the magnitude is of the potential lung cancer burden? That, of course, doesn't consider the challenges in the follow-up after that. But do you think there's something to say for that? Or do you really think we should maybe disregard that point of view, considering these challenges in that might be there in the diagnosis or the treatment, depending on the specific setting?
Yeah, I think people forget that TB is a very interesting disease because there is a very cheap and very effective cure. Right? $10 of antibiotics and almost everybody gets cured. This is kind of unique. Right? Lung cancer is a very difficult disease to cure, and you have to be very early, and for that you need to have a lot of things in place. So yeah, it's maybe interesting to know that, but that is not the main reason I would say to do a screening program.
Yeah, thank you for that. I think it's interesting. It's also obviously this is from us as a AI developer. It's a topic and a question that we get quite a lot of. Can you use AI for this application or for pneumonia or for lung cancer, COPD, and so on? And that's also why we wanted to put this webinar in together, because we're optimistic in some of the applications, but we do also see the limitations on that. And we always say, like, you kind of need to have three things in order to have a solid application of AI in the medical field, which is you need to be able to have something that you can technically make for it that works. I think people need to consider that there's a challenge that requires a solution, right? Because I think a lot of cases we're building AI because we're seeing a solution because we can technically make something, maybe not because partners see a problem in that. And then there needs to be some kind of a business case or a reimbursement behind it, not necessarily for the profitability of vendors involved, but also for the sustainability of rolling that out. But very interesting to hear your thoughts on these questions. So thank you for that. Professor Helen had to leave, unfortunately, but she answered some of the questions in the live Q&A, so I'll answer them on her behalf. So there was a question from Daniel saying, is there any information on the timeline to show when to follow up or repeat screening for those screened earlier? Could be of great significance for high burden settings screened and remain negative. So Professor Helen mentioned there's little data on repeat screening in the community, but repeats round of screening were used in the past, in the 1950s also, and have been used in the mining sector. And they decided to offer annual CXR chest X-ray screening. And they've only been working just over a year on this and hope to gather more information about who is repeatedly screened and what it can tell us. So I think that answers that question as well. There was a question also from somebody whether they can join Helen's group to discuss the weekly X-ray discussions. Unfortunately, that's a closed discussion. Professor Helen mentioned also because clinical data there is discussed, but she did mention that she also encourages others to start these similar kind of meetings in their specific section, also to share knowledge as well. I believe we're already going a little bit over time, so I think I'll close it with that. I wanted to thank all of our speakers, so Professor Bram, Professor Rodney, Professor Helen, and Edwin on our side, and of course our CEO Guido, for sharing their thoughts on these matters. I want to thank everybody who dialed in today. I think the amount of questions, the amount of people joining showed that there's a lot of relevance on this topic, and I'm sure that in the coming years we'll see a lot and hear a lot more of it. I hope we've been able to show the potential and the promise that we see with AI, but as well some of the limitations and considerations that are there indeed as it is now. And like Edwin mentioned on our side, hopefully you've been able to share some tips on questions we should probably all ask ourselves when we start considering these kind of tools, so that we can have sustainable and also responsible implementations of AI towards the future. So thank you everybody for being here today. I'll close it on that. We'll come back to you with the recording and the Q&A sheet and so on. And I wish everybody a very good day ahead. Thank you, everybody. Bye.
Yes, thank you, Bram, Rodney.